This was a wonderful presentation and could not have been elaborated more. I would request the chairpersons to both of them to please add a few words.
Thank you, Dr. Sejal. That was such a beautiful, clear, concise, and crisp compilation of all the applications of hysteroscopy to infertility. And the last part where the PRP and stem cell is really interesting, because in Northern India, there were a lot of unqualified people performing MTPs in the past, more than 1 decade ago. And we still find patients with bony parts in the endometrium embedded in the myometrium, which sometimes requires the multiple attempts of hysteroscopy to remove the little bone spicules. And some of these patients are so, the endometrium is destroyed so completely that they are never able to have a child. So, Dr. Manu is there?
Yes. Ma'am, you are mute. Yes, ma'am, you absolutely said in refractory endometrium, we are hopeless and we are usually frustrated. What additional we can do? We have usually we give all kind of cocktail regimes, and they are, you know, all the time cancellation of the cycles are really painful to them. And with the this difficulty in getting the surrogacy and all that, it is now many centers have stopped only doing the surrogacy, including myself. So that then it is the, like, you know, we have to offer and we have to try in correcting and the rejuvenating part rather than finding the other options. So let us hope it come out with the good evidence that and the good standardized technique, like everyone is doing in their way. I show just what I do, but there is nothing like standardized. Like there is a proper treatment. This way you should prepare the sample. This way you should introduce, and there is much time duration between the collection and the introduction. So this has to SOPs has to be come out with the good number of evidence.
Ma'am, one question more. In the case of intracervical and intrauterine adhesions after good adhesiolysis, do you find that when some of these patients get cervical incompetence and preterm labor or like that, trimester losses? Has it happened in your center or in your knowledge? Should we think about and cerclage electively for these people? That's what I'm wondering.
Madam, we do these procedures usually with the 4 mm of the complete assembly, that is 2.9 mm telescope, and complete assembly is 4 mm. So 4 mm dilatation usually won't damage the cervical or the, you know, the muscularis, and that won't affect the cervical competence. But they may have the inherited other issues of the uterine contractions because of the problem. So that can cause the dilatation or the taken off or the shortening of the cervix. So there may be, like, we all usually see even a fertile primey, sometimes they appear with a weak and incompetent source.
Yes.
So we do not do prophylactic cerclage in all, but yes, we such a very precious pregnancy, we monitor them very strictly for each visit with the cervical length, and that is there. And if we find it shortened out like less than 2 centimeters, then we advocate for the encirclage.
Thank you, ma'am.
Dr. Sejal.
Yeah. Yes, madam.
Nowadays, thank you so much. Nowadays, hysteroscopy has become a primary tool, just like ultrasound in patients of infertility. I will like to ask you one thing. Have you ever used mesoprost before doing hysteroscopy?
Madam, I have never used it. But the study says you may try. There is no harm in doing it. Only thing is the patient may feel some cramps or bleeding, spotting. That can be explained to patient beforehand very well. But I do all my hysteroscopy under general anesthesia. I am not doing office hysteroscopy. So usually these smooth muscles are relaxed only under the anesthesia. So I usually do not require. And for postmenopausal women and all that, the receptors may not be there active to introduce the mesoprost, but there is no harm. That is your choice, ma'am.
You're using short GA or full GA?
Short GA.
Ma'am, what time do you keep them admitted? You keep them inpatient for then few hours or whole overnight?
Ma'am, just 2 hours before the procedure, because we give the test dose of antibiotic before that, so that will half an hour before, so preparation and consent and etc. can be so 2 hours before the, at least 1 to 2 hours before the procedure, And we discharge 2 hours before the procedure. So,
After.
yeah, after the procedure, yeah.
And how are you using vasopressin as you mentioned in your
It's
speech?
I have used only couple of cases where it was a really difficult to introduce in three just like we do the cervical block for before the MDP at the like 2 o'clock and the 10 o'clock or the 4 o'clock and this.
You're diluting the vasopressin
No,
like
just
you have been.
injecting at the fornices, madam. Uh,
And are you using the antibiotics before hysteroscopy 2 to 3 days earlier and later on also?
One
Free
shot.
of antibiotics.
Yeah, one shot of antibiotic just before in the like 1 hour before the procedure. Before taking the patient to the OT, 1 hour before.
Thank
Dr.
you so
Sejal,
much.
Yeah, thank you, madam.
Dr. Sejal, it was a nice presentation. I have a query in the mind. Actually, I was in between offline also. You told you put the PRP through the hysteroscopy and with the ovum pickup forceps.
Ovum
it right?
Needle.
Needle, sorry, is it right? So how do you introduce the ovum pickup needle through the channels?
To the operating channels, ma'am, ovum pickup needle. We just prepare the PRP.
Fine.
The patient we take into the OT, we give the blood sample. By the
Mhm.
time of anesthesia, painting, wrapping, they takes usually 20 minutes for preparation of the PRP. Once the PRP is ready, we are all ready with our assembly, and we do
Okay.
just the diagnostic hysteroscopy first. If there is anything to correct, we do it first. Then it is done. Then my embryologist will activate the PRP, and immediately we install. Once the activator is introduced, we mix the PRP with activator. We immediately install. So now the installation is done with the PRP needle that is go through the operating channel.
Fine.
Then we just inject it in
In
the
subendometrial layer.
subendothelial. Yes,
Subendothelial layer.
Yes,
So the difference is like when we are putting the PRP in the cavity. So what is the difference of outcome? Do you have any study like we are putting the PRP in the endometrial cavity via the ET catheter,
Yeah.
and you are putting in a subendometrial layer through the hysteroscopy. So what is the difference? Or do you have any study like that?
Sir, madam, it says that this kind of any activators, cellular stem cells or PRP requires around 30 to 40 days to act upon. So intrauterine, that is PRP installation, may not be that is why we are not getting result with just intrauterine installation, because it will seep off and may only the basal layer where the endometrium grows has not been get the benefit of this installation. So nowadays I have also done this intrauterine just like IUI putting up, but haven't seen any benefit.
No, but we people are finding the results and we didn't have a study. And secondly, if putting a patient over the anesthesia, if we need a hysteroscopic correction, like we have some other hysteroscopy work to do, or we are planning to do a diagnostic hysteroscopy, if some centers do mandatory hysteroscopy before IVF, then I feel, but even though if we are putting a PRP, I feel it is first after 48 hours. And normally we do on those 6 days, 7 day, 8 in the transfer cycle. So you're putting, I'm a bit confused. That's why I asked you the question.
Ma'am, I have also done this intrauterine PRP. These are the patients where nothing works, right? Still this subendothelial PRP and stem cells are still experimental. These are the cases are screened out through, and we have given all cocktail regimes and GCSF and everything. But when there is nothing works, then this is as an option. We explain patient thoroughly. It is maybe we may not get any benefit.
So you might be putting the stem cells in the subendometrial layer, because when we are
it is much more promising, ma'am. But for the stem cells and to it's not everyone's cup of tea for our patients. So PRP.
But when we are putting PRP, the spurts occur in 48 hours or so. If we are taking the maximum benefit of PRP, that's why I'm asking. You are doing a hysteroscopy, or sometimes you are doing some corrective thing, sometimes you are not doing the corrective thing.
And these are the different kits. These are the different kits of monocellular PRP. So these are not just the platelets. It's the
No, we had the activator wala.
हाँ.
We also use the
But they
activator
only
is there
recommend
inside.
it. They only recommend it to be done in previous cycle. In like day 5 or 7 of like 5, 6, 7 of the previous cycle, and then following the next, she will get the analysis once, and following that, we start the HRT. I'll
So
send
you were
you.
telling that the PRP effect lasts for next cycle too.
That yes, ma'am. The activations that occurs with the basal layer will
Okay.
grow the endometrium for the next layer. So I'll share you the detail by WhatsApp.
Okay, sure. We will discuss. Okay, thank you. Thanks.
Thank you, madam. Thank you.
Thank you.
So thank
Ma'am,
you.
before we finish the session, there is a question from Dr. S.K. Sahu. Which book to refer for hysteroscopy and laparoscopy, please guide. I hope you will be coming up with some standard text of your own, and that would be helpful for everyone. But for now,
Yes, sir. So we have an endoscopy practical tips and tricks, and that can be, I will share you. Just message WhatsApp me on my number, and we'll share you the books link. And there are some books are available also online. So I'll post my phone number here, so you can WhatsApp me. I'll share you the link for the books. Yeah. Okay.
thank you so much for this wonderful session. I would like to thank both chairpersons as well as the uh, wonderful session that we had, and such an enlightening session it was for us. I would like to request Dr. Uma to please introduce everybody for the next session. And we will move on to the second session of the seminar. Is Dr. Uma available?
You are mute, Dr. Uma.
Hi,
There is some
Sejal.
network problem, I think.
Yeah. Hello, madam. Hello, Aruna ma'am.
Hi, Sejal. Nice to see you here.
Thank you, ma'am, for joining, ma'am. Thank you.
Yes, you were there, so one has to join, no? There's so many others. I've just forwarded it to so many of them.
Thank you, ma'am.
Let's hope many of them join. It will be very beneficial.
Yeah.
Sejal ma'am, is Dr. Deven joined? I haven't seen him as yet.
We can start with your this. That is okay. I'll make it sure. We can start with Dr. Damodar.
Yes, ma'am.
Deval Jogan is joined. Is there?
Yeah.
There?
Is mute. Yeah, Deval is joined already, I think. Is there?
Yeah, okay, let's go with him only then.
But
Please.
I don't know why he's on the mute and
He's not answering.
Sorry.
Deven bhai, you're here?
Deven Jogal, I can see him logged in, but video and mute is off.
Okay.
Yeah.
Yes, some internet issues, so okay. We can start. No problem.
Should I go ahead?
Yes, please.
Okay.
So, Dr. Piyush, you can introduce the chairperson.
Sure, ma'am.
Yeah. Please introduce the chairperson.
I would like to the session which will and just 1 second.
You can share the screen. Dr. Uma, you are not audible.
Thomas is views on sharing.
Is some network issue.
Screen is being
Uh,
shared.
I think so. Dr. Piyush, you are not clearly audible. Just place the yeah. Shall I introduce?
yeah, maybe Sejal ma'am, you somebody can introduce and then you can go.
So let us introduce, change the slide. Chairperson, please. Both of your volume is not there. Please change to the slide. Uma, are you sharing the screen?
Yeah, it's her screen that she's the one who's sharing the screen. Yeah, I think slide is changed.
Yeah. So it's my pleasure to introduce Dr. Sangeeta Sinha ma'am. She is ART consultant and laparoscopic gynecologist, director of Srijan Bhilai Test Tube Baby Center, and ISAR. She runs the ISAR accredited center, FOGSI recognized infertility training center, FOGSI recognized endoscopy training center, IMA and AMS approved center for fellowship courses in infertility, and Center for Laparoscopic Training Center by the IMA and AMS approved. She is president of FOGSI Bhilai Society. And,
Hi everyone.
and
Hi everyone. Good evening. Hi Sejal.
yeah. And she's IMA Durg Women's Wing India 2023. Wow, ma'am. We are proud of you. So thank you so much for being here. And Dr. Kirti is she's the secretary, and she's the director of Revival Medical Center. So would you like to introduce Dr. Damodar? Sangeeta ma'am?
Yes, yeah. Please, and
Please display CV. Yeah.
the CVs. Yeah, it's the honor to welcome Dr. Damodar R. Rao. He is presenting the next session, and he's the managing committee member, National IAGE 2022-24, Tamil Nadu IAGE General Secretary, co-convener of a special interest group Endoscopy IFS 20221, organizing secretary South Zone IAGE Conference 2011. He's organizing secretary of UVA FOGSI. Area of interest is laparoscopy and fertility. His achievements is San S. Ratnam Young Gynecologist Award 2022, Best Paper Award in Laparoscopic Suturing Technique of Myoma, Best Paper in Hysteroscopy in Infertility, and Best Paper Award for Laparoscopy in Neovagina. That's great. FOGSI Future Award, lots of publication in his credit. So we welcome you, Dr. Damodar, for your presentation.
Yeah.
Stalwart, please.
Thank you, ma'am, for
please.
that kind introduction.
Yeah.
Thank you, dear Damodar, for taking out this time. And
thank you, ma'am, for this opportunity, and wishing you all the best.
Thank you.
Without
please stop
further
sharing
ado-
this and let Dr. Damodar share the screen.
Yeah. My topic for today is on Isthimocoele. Is it visible?
No.
Restart, please. Yes, now visible.
It's visible.
Yeah. Okay. I'll just make it. Yeah. Is it on? Can you see the full screen?
Yeah.
Yes.
Okay. Okay. So my topic is on Isthimocoele. This is something that's we're seeing it more frequently, or maybe diagnosing it more frequently. Basically, it's called by various terms like uterine niche.
The voice is very low.
Sorry, 1 minute. Maybe I'll have to come closer to the lab. Is it better now?
Yeah, it's better.
Yeah. All right. It's otherwise called as uterine niche, uterine isthmocoele, caesarean scar defect, uterine dehiscence, diverticulum, caesarean niche, caesarean delivery scar pouch, right? It has various terms, and it's an iatrogenic pouch-like defect at the site of the previous caesarean scar due to defective tissue healing, right? So basically, we all identify this usually radiologically and sometimes by the symptoms of the patient. It's seen as a hypoechoic field within the lower uterine segment, indicating a discontinuation of the myometrium at the uterine scar of a previous cesarean section, right? So it is a iatrogenic pathology, right? It's seen in about 70% of women with previous cesarean section. You can usually diagnose it with the transvaginal ultrasound or with the some amount of saline installation also. And underestimation is there because many of these are asymptomatic and clinicians may not even recognize this niche as a cause of the symptoms due to unawareness also. And it's increasing with increase in the number of previous cesarean section, right? So what are the risk factors for formation of this, cesarean scar defect? So one is if you do your cesarean late in labor, right? After when the cervical dilatation is more than 5 centimeters or more than 5 hours duration of labor and advanced fetal station, you can form. These are all risk factors for formation of a niche. Or long active labor prior to the emergency cesarean section is also considered as a risk factor. If you give a low incision, right, low uterine incision towards the cervix, because of the mucus secreted by the glands, it can interfere with healing. Or cesarean sections done in advanced labor after cervical effacement can also be a cause, right? One is, when you give the incision. Next is how you close the incision can also affect the healing, right? If you just do a single layer deciduous sparing closure technique, an incomplete closure compared to single full thickness closure, 95% of the patients with niches have had single layer closure without closing peritoneum, right? So basically they're saying that you should approximate everything properly. You should take the deep layers and ideally do the suturing in 2 layers, okay? That will give good apposition and decrease the chances of formation of a niche. Another thing is non-perpendicular suture, that is irregular myometrial closure also, right? Sometimes we don't close it properly. It can be irregularly closed, and that is also a risk factor. Locking sutures are also a risk factor. And to minimize the risk, double layer uterine closure using non-locking sutures is the optimal closure technique that results in thicker residual myometrium, right? Then, of course, your hemostasis, tissue ischemia, devascularization, excessive tissue manipulation contribute to poor scar healing and adhesion formation, and hence form a niche, right? After your cesarean and after you put this, your suturing, adhesions can form. And when you have a uterus that is ventrofixed, this again can exert a kind of pull on the scar and it can affect the wound healing. And then you can see how a niche can be formed, right? So in retroflex uterus, the effect of gravity on the uterine corpus can also increase counteracting forces. Large niches are mostly found in retroflex uterus. So usually you will generally see patients who have complaints. These are usually uteri which are attached to the anterior abdominal wall, like you see over here, right? You usually see a band attached to the anterior abdominal wall, and then you'll see the niche under it. Or you'll see something like this, like in this photo, where the bladder is really pulled up and the uterus is retroflexed. Patient factors, of course, you have genetic predisposition, you have gestational diabetes, and advanced BMI as risk factors. Mostly they are asymptomatic, right? 30% are symptomatic and they have gynec complications. They might have a post-menstrual spotting, right? That is one of the complaints due to the collection of the menstrual blood. The anterior edge of the niche obstructs the flow of menstrual blood, and poor contractility of surrounding fibrous muscle retains it, which is then discharged gradually. So after she's finished her menses, she'll continue to have some sort of spotting or a brown discharge. Or prolonged bleeding can also impair menstrual drainage and prolonged flow, or she can have intermittent spotting, or she can have mid-cycle intrauterine fluid accumulation, and this is seen in approximately 45% of the women. Some women might have pain like dysmenorrhea, chronic pelvic pain, dyspareunia. These are not as common as your menstrual symptoms, but these are also seen. Size of the niche is important, with larger niches being more likely to present with pain. When do you usually see this? You usually see this in women with secondary infertility. That is, they come to you with infertility and then you do a scan for them, and usually you will see a niche or Isthimocoele in such patients. What are the problems it can cause? You can have problems during IVF. You can have a difficult ET in these patients, and chances of unsuccessful IVF are higher. Bladder dysfunction and scar abscesses are also seen. Obstetric complications in future pregnancy. You can have a cesarean ectopic pregnancy, that is when the pregnancy implants in the niche, or you can have a placenta accreta, scar dehiscence, and uterine rupture, right? So how do you diagnose this? Like we already discussed, like you have your transvaginal ultrasound or a saline infusion sonography, MRI, and of course on a hysteroscopy also you can see it. So basically on your ultrasound, you'll see an anechoic space at least 1 millimeter deep, right? With or without fluid, at least 2 millimeter deep in the myometrium at cesarean scar sites clinches the diagnosis, right? And what is very important in deciding the treatment is the residual myometrial thickness. That's the vertical distance between the uterine serosa and the apex of the defect. Basically, it talks about how much of myometrium is available between the bladder and the cavity. So based on this, if it is more than 3 millimeters, then you can do a hysteroscopic approach. If it is less than 3 millimeters, then you have to go and do a laparoscopic approach, right? So here you can see the residual myometrial thickness, what we're talking about. And they also have other features that you describe about. They can be round, oval, droplet shaped. They can have various protrusions. They can also have, various shapes and sizes. So here you can see, so it's not like one single pouch, right? You might see more outpouching. You might see vertical limbs going in different directions. So you have to, while treating it, you have to be, aware of all these things. The European Niche Task Force talks about depth and width, length of the defect, and the residual myometrial defect, and did not specify any assessment of morphology of the niche. So these are the three most important things. Of these, the most important is the residual myometrial defect. On hysteroscopy, you will see concavities in the isthmus with a prominent distal ridge. I'll show you photos and videos later on. On laparoscopy, you will see ballooning of the lower segment, right? What are the indications for treatment? Basically, secondary infertility, previous scar ectopic, recurrent miscarriage, AUB, routine repair of incidentally diagnostic niche with no plans of future childbearing is not recommended, right? So this is sort of a guideline for you. If they wish to conceive and RMT, that's the residual myometrial thickness, is more than 3 millimeters, then you do ultrasound monitoring of the lower uterine segment in the case of pregnancy. If it is less than 3 millimeters, you can go ahead and do a laparoscopic repair. But here also, if it is usually people who wish to conceive, right now the consensus is it's better you go and do a laparoscopic repair because you give good strength to that scar, right? But if they don't wish to conceive, and if it is more than 3 millimeters, you can do a hysteroscopic approach. And if it is less than 3 millimeters, you can do a laparoscopic repair. Or in some patients, if they've finished childbearing and if they're in their late 40s, they might even opt for a hysterectomy. Right? Medical treatment can be tried. LNG was not found to be very useful. Usually, such people require surgical treatment. So it's either hysteroscopic approach or a laparoscopic abdominal approach, right? Hysteroscopic approach basically do a resection of the niche and then you coagulate that area. I'll take you through the video of this. So basically, this is the niche that you can see, the isthmocoele. It has a cephalad edge and it has a caudal edge, which is closer to you, and that's the pocket. So whatever is pyramidal, you try and bring it, you have to try and make it flat. So you have to resect the cephalad edge and the caudal edge, and then you use a roller ball later on. So there you can see that is the niche. So you have to, resect this edge and resect the caudal edge, and then you have to try and make it flat. Complications during hysteroscopy, you can have uterine perforation or bladder injury, cervical incompetence with proximal rim resection, and uterine rupture very rarely. So this is what we do if it is if you're going by a hysteroscopic approach, right? So what you should do is basically resect the cephalad edge, right? So you can see that this is a bipolar resectoscope that is used. Having 18 French resectoscope is quite useful rather than the bigger resectoscopes, right? So the mini resectoscopes are useful in such areas. So the caudal cephalad edge you take out, and the caudal edge this is the caudal edge being taken out, right? So you do both these areas till you think that they have formed a, it's in a single surface, right? There's no pocketing in that area. And once that is done, all you have to do is run the roller ball, right? So you can see the isthmocoele, and then there you can see the isthmocoele very well now. You can see abnormal vascularity over there, and what you have to do is just run the roller ball in that area and then just destroy all the tissue over there so that there is no secretion of any sort and there is no pocket in that area, and that there is no flap-like structure that can actually collect the blood. So this is how you do it histoscopically when the RMT, residual myometal thickness, is more than 3 millimeters, right? So if you're doing it laparoscopically, there are various techniques that can be done. You have to identify the defect by histoscopy, then you can introduce a Hegas dilator, or you excise that area and then you reapproximate in 2 layers, right? So this is a patient who was for fertility, and her RMT was less than 3 millimeters. So we went ahead with the laparoscopic approach. But first what we did is we just go and resect a little amount of tissue histoscopically so that when you show the light, it can be seen nicely. So this is sort of a combined approach. You resect the cephalad edge and then you also resect the caudal edge. And once this is done, then you go up laparoscopically. Usually you will see the bladder is quite pulled up, and you will also see these 2 strand band-like structures on either side, right? That is usually the boundary of the isthmocoele. So basically you push the bladder down. Here you can see that the bladder is being pushed down. And once this is done, you can, from below, you can go ahead and show the histoscopy, and you decrease the laparoscopy light, and then you can see that the niche is nicely seen as a halo, as a glow over there, and you go ahead and resect that area. So you can see that we're just going ahead and making that incision deeper, and you introduce a dilator from below just to make sure about where you are. You always have to be careful of the uterine arteries on either side, right? So care should be taken. There you can see that the scar tissue is removed, and then you introduce a dilator so that you do not take the posterior wall also and obliterate the cavity, and then you can do the closure with a V-lock. So the closure approximation has to be, deep, thick bites have to be taken so that there is good approximation. Do not pull the V-lock fully, otherwise you'll not be able to see the depths and take a bite. So just pull it little bit, and only at the end you can tighten the whole suture, whole wound, right? Do not pull the V-lock after each bite that you've taken, right? This is the end of the first layer. And then this is the second layer that is being taken, right? I always have the habit of taking a vicryl in the end and knotting the V-lock with it so that the V-lock doesn't protrude out. I do that even for my myomectomy, so it's just out of habit that I've also done this over here. So that is your laparoscopic approach, right? So some people also have the habit of plicating the round ligament so that it doesn't fall back. Here present. And so that the wound heals nicely, right? Some people also have the habit of doing that. Vaginal route has been done by some people in India. We have excellent vaginal surgeons. They say that if the niche is quite low down, then you can approach it vaginally and then you can close the wound, right? So the preference of the route, like I said, if it is hysteroscopy for smaller niches, and if the RMT is more than 3, and if it is transabdominal, that is laparoscopic approach or robotic, whatever you want to do, then if the RMT is less than 3, that is what is done. So surgical management indication for symptomatic CSD, surgery is currently not indicated for prevention of adverse obstetrical outcomes. Symptomatic resolution and improvement in rates approach almost 80 to 100%. Best surgical approach for patients who desire future fertility with RMT less than 3 millimeters is a laparoscopic approach, right? Then there was also the study done in 2020, and the results were not very conclusive. They said the hysteroscopic approach had a pregnancy rate of anywhere between 6.6 to 100%, laparoscopic anywhere between 21 to 75%, and vaginal again 39 to 51. But they said the lack of standardization and inclusion criteria was not the best, and hence we require more studies for the same. Right? When can patients get pregnant after the repair? Lack of available evidence is there, but generally they say you can wait for more than 3 months post-op to conceive, and recommended delivery by scheduled cesarean section not later than 38 weeks. So this is what I've already shown you before about hysteroscopic approach or laparoscopic approach, which one to do. Yeah, thank you. Thank you so much.
So, Dr. Damodar, it was a very nice presentation. Very nice, I think, fully and elaborate. There's one or two queries in my mind, like why it is more commonly in retroflex uterus?
Yeah, so in retroflex uterus, what happens, ma'am? That is the scar, the whole weight of the uterus is pulling on the scar, right? So that area is not allowed to heal nicely. So then you can see that that area, the scar doesn't oppose nicely, and then there is a gap that is formed over there. So in retroflex uterus, definitely the healing of the scar is not the best. So there is more pull on the scar, and the healing is affected. So it is more, seen more in retroflex uterus.
And what is your preference? Like, what do you prefer, or you go by rule? Like laparoscopic repair or hysteroscopic repair, or you go by rule?
We come to a consensus that if she is for fertility, then go laparoscopic, because you are going to, if you do it hysteroscopically, there is a chance that you're thinning that area. You don't know what is going to happen in the pregnancy. So you rather play safe. Whatever the residual myometric thickness is, go laparoscopic approach, remove the scar, and enforce the nicely.
Yes, yes. And it's very nice presentation, Dr. Damodar. There is one question in the chat box. Bilateral uterine artery ligation can cause Isthimocoele. Is question from some of the audience, like
not really come.
I don't think so. Yeah, I don't think so.
Papers I've read, ma'am. No.
And one more query is like, what is the best way you diagnose? Like, I think, what is your preference to diagnose the Isthimocoele?
Saline infusion sonography will give you a good delineation of
the best.
Yeah, that's the best.
Okay. Okay.
So,
any
another question, ma'am, can I ask?
Yeah, sure, ma'am, sure.
Can you prevent it literally? And whether it matters where we suture single layer or double layer, or including or excluding residua?
Yeah, they were saying that, suture in 2 layers, you can include the decidua also, and do it in 2 layers nicely so that the muscle is approximated nicely. I think I showed a couple of diagrams where do not use locking sutures. Let it be non-locking, so that the tissue should not get sort of strangulated. So all these are important points. 2-layer suturing, non-locking. These are all important points for good healing of the scar.
Yes. Yeah. And if it is not more than 5 centimeter dilatation, then the chances increases.
Yeah.
Chances increases. It's very nice presentation. Very nice.
Thank you.
Thank you, Damodar. Thank you, madam.
Thank you.
Thank you so much for the wonderful presentation, sir.
Thank you.
And it was so enlightening for all of us, starting from diagnosis to treatment, and everything, I guess, was covered. And I don't think there is anything left in this topic to study from any book. The way you have explained everything, and especially the nitty-gritties on how to suture and how to prevent, and all of these things have been a very enlightening session for us, sir. Sir, before we finish the session, there is one question that has been asked twice. by Dr. Yukti. It is decidual sparing advice during suturing to prevent isthmocoele.
Yeah, we just
We
discussed it.
covered. Yeah, we covered.
We covered that.
So
Thank you, Dr. Sejal and Dr. Damodar. Dr. Sejal, all the best, and I have a patient in the OT. So can I leave with
Yeah,
your
sure,
permission?
ma'am. Thank you so much for your time and
Thank-
your inputs.
Thank
Yeah.
you. Thank you, and all the best. Thank you.
Thank you. So we'll
Thank
move ahead with our next speaker is ready, Dr. Deven Jogal, sir.
ma'am.
So please kindly introduce chairpersons.
Yes, sir. Yes, ma'am.
So now, am I audible?
Yes, yes, you are very much clear.
So I would like to welcome Dr. Deven Jogal, sir, who is a speaker for our next session, Standard Steps in Endometriosis Surgery. So now I welcome our chairpersons, Dr. Rashmi Sharma, ma'am, and my CV PPT
Your
is
screen is not
visible?
visible. Yes. No,
My
no,
screen
no,
is
not
not
yet.
visible. Can you allow me screen sharing, or else you can share the screen?
Wait, let me try.
I'm not being allowed. Okay.
I guess my screen I've started sharing. Is it visible?
Yeah. So please share CV of Dr. Rashmi Sharma, ma'am.
Yeah.
So Dr. Rashmi Sharma, ma'am, is a senior consultant Apollo Hospital, Bilaspur, and president FOGSI Bilaspur. And welcome, Dr. Rashmi Sharma, ma'am.
Thank you, ma'am.
So next, yes, ma'am. And next we have Dr. Pratibha Makheeja, ma'am, consultant in ART and Gynae endoscopic surgeon at Makheeja IVF Bilaspur, Chhattisgarh. Madam has worked as assistant professor in the department of Pandit JNM Hospital, Medical College, Raipur, and she has done basic diploma in reproductive medicine, advanced diploma in reproductive medicine, and fellowship in ultrasound, Mumbai. She has been treasurer in ISAR Chhattisgarh 2023-25, and she has been active member of various societies, ISAR, IMA, FOGSI, IFS. And she is recipient of various awards like Lifeline Excel FM Award Bilaspur and Women Power Award Bilaspur. So welcome, Dr. Pratibha Makheeja.
Thank you, ma'am.
So I would like to chairpersons to introduce Dr. Deven Jogal, sir, now.
First of all, I must thank Dr. Sejal Naik for inviting me to this platform. I'm really thankful to you. Now, our next speaker is Dr. Deven Jogal, sir. He is the director of Jogal Women's Hospital, Bhuj, that is Kutch. And he's head of minimally invasive surgery department of OBGY Adani Medical College, Bhuj. And he's a member of video review of committee IAGE. He's an executive committee member of IAGE Gujarat chapter 2021, and is the executive committee member of IAGE. Then he's established the first dedicated third Gynec endoscopic center in Kutch. He's winner of Gujarat Gynec Excellence Award, winner of IAGE Young Skill and Excellence Star Award with AGL. It's great, sir. Organized and participated as faculty in Advanced Gynec Laparoscopic Workshop, and he has been coordinator of Project Eagle by IAGE, and he has been invited as faculty in various national and international conferences, and he has trained more than 100 gynecologists in laparoscopy. I welcome you, sir, for your talk on and standard steps in endometriosis surgery.
Thank you, ma'am. Thank you very much. And I would like to thank Dr. Sejal Naik for giving me such a nice opportunity. Today's my topic is standard steps in endometriosis surgery. So please allow me to share my screen. I'm sharing my screen. Is it visible?
Yes, sir.
Yeah.
Yes.
So what usually we do is I divide my topic standard steps of endometriosis surgery in two categories. One is conservative surgery, one is hysterectomy. Okay, so conservative surgery where uterus has to be preserved and fertility is the concern, or uterus has to be preserved, and the radical surgery, radical means endometriosis point of view, where you have to remove the uterus. So steps for conservative surgery, usually the first step is sigmoid immobilization. So always first when we go in, even for conservative or for TLH, if for conservative surgery, first is sigmoid mobilization, second step will be bilateral ureterolysis, third step will be bilateral chocolate cystectomy, if at all chocolate cysts are present. Fourth step will be ovarian fixation to the lateral wall of the abdomen so that your pelvis will be clear to work in. Fifth step will be bilateral pararectal space dissection, and the last step will be rectal dissection and rectal shaving. So these are the standard steps, and I'm going to show these steps in my video also. If we talk about surgery for total laparoscopic hysterectomy in endometriosis, then first step will remain sigmoid mobilization, second step will be ureterolysis, third will be pararectal space dissection. If we are going to remove adnexa, then next step will be adnexa removal to make more space, then bladder dissection, then rectal dissection and shaving if required, and then proceeding for TLH. So all these steps, I can understand that it is very difficult to imagine things, that how we should do it. So let's see how we can do it. So this is the video and standard steps of doing TLH or in conservative surgery. So this is the, my voice is audible, right?
Yes, yes.
Yeah. So this is the standard step in which the first step is adhesiolysis. That means restoration of anatomy, what we do. Here you can see that sigmoid colon is adherent to the lateral pelvic wall, and it is the congenital adhesions of the sigmoid, we can say. This is very much necessary to remove all these adhesions, because then you will get more space inside the pelvis and your rectum or sigmoid colon is away from your dissection area. So I'm working with active blade or of my instrument. You can use any instrument of your comfort. You can see we are holding rectum or sigmoid colon with epiploica. So it is better to hold it with epiploica, and you should directly not hold with serosa. You can see here, this is the impression of external iliac artery. We still want to mobilize this area a little bit more so that we get good access or good space while doing ureterolysis. So as we have already discussed, first step was sigmoid colon mobilization. Second is ureterolysis. You can see here ureter. You can see peristalsis of the ureter from here. So we are going millimeter by millimeter, taking out all the tissues which are lying on the ureter. We usually work remaining on the top of the ureter. You can see here ureter very well. With my active blade, I'm working and I want to remain on the top of the ureter, taking out all the tissues which are attached to the ureter, taking care of the vascularity. You can see their vascularity. I'm not going to disturb any vascularity there. See, this is the entire course of the ureter. You can see left ureter, which is under my vision. That was on the left side. Now, as we have discussed that if it is TLH and BSO, we have to do next dissection before going for the proceeding for the TLH, I mean to say. So that was left side round ligament, which has been cut. You can see here uterine artery from its origin in the retroperitoneal area. And you will be able to see relation between uterine artery and ureter. This is the left uterine artery. You should be careful because just below this uterine artery, there is uterine vein. Always try to coagulate it first and then you try to cut. Now I'll be proceeding for the bladder dissection. In bladder dissection, I think vaginal manipulation or manipulation of the uterus plays a very big role. You have to, you have to teach your assistant also how to assist so that you will get one extra port. This is kind of skeletonization. We are not going deep inside. Adnexa removal is one of the very important thing, as if you want a good space in the pelvis, you have to remove adnexa. This is IP ligament, what I am doing or I'm cutting right now. And that's the ovary. So this is left adnexa, which I'm planning to remove. You can see this is a fat. You have to take care of the rectal serosa. It should not be attached. Now here, the role of ureterolysis is very important. You can see ureter, which is lying just below in this area. I can do dissection very well because I know that ureter is away from my dissection area. And that is very important. Still, even having proper idea about the ureter, it is always better to keep your eye on the ureter. You can see ureter very well here in this area. Removing adnexa will give you more space. You will be able to see after removal of adnexa that we will have very good space. Second thing, it will be useful in doing rectal dissection also. So that's the left adnexa, which is out. And you can see we are proceeding further, going deep inside. Now you can appreciate that ureter is lateral to my dissection area, and area where I'm doing dissection is called as pararectal space. I have to take care of the fat. So the dictum or the rule is always remain lateral to fat. You can see there hypogastric nerve, which is very important to identify and preserve. So it is not like in endometriosis surgery, you cannot identify pararectal space and you cannot identify hypogastric nerve. It is almost always visible and you have to preserve that. These are the affected tissues by endometriosis, which ultimately we will have to remove. If at all uterosacral ligament is involved, it is better to remove. These are the free space. As I have already mentioned, we have to remain lateral to fat. You can see there I'm remaining lateral to the rectal fat. Now the left side is almost clear. Whatever you are seeing right now, we are working on the right side. Again, right side also ureterolysis. Same thing, I'm remaining on the top of the ureter, taking care of vascularity of the ureter, which is, believe me, very important. You can see how my assistant is holding peritoneum, which is covering the ureter, which gives me extra space of working. Now we are on the right side going for pararectal space dissection. You can see I have to remain just lateral to the rectal fat. And you can see there the yellow fat, I'm remaining just lateral to that yellow fat. It is always advisable to go to pararectal area after doing ureterolysis, because then you will have proper idea about the ureter, that where exactly ureter is lying. And if you are in a correct plane, there are very less chances of bleeding and injury to the vital organs or vital thing like nerve, ureter, and vessels. Here you can see I'm very close to the rectal serosa. But then I have exact idea that rectum is away from my dissection area. Whatever my assistant is holding in right port is adnexa, and I'm following a fat. Again, I would say remaining lateral to fat. So you can see here very well that I'm remaining lateral to fat. Here, and ureter is lateral, far from my dissection area. Whenever it is endometriosis, I always love to use rectal probe. That guides me, exactly that from where rectum is going and where I have to remain. Now we are proceeding for right side adnexa removal. So that's the right side adnexa. You can see here, this is a retroperitoneum. And we are making space in the broad ligament to safeguard the ureter. This is IP ligament. After cutting, whenever you cut IP ligament, even in normal surgery or routine surgery, if you are going for TLH and BSO, it is always better to make window in posteriorly for broad ligament to safeguard the ureter. Now, this is kind of little bit of lateralization of the ureter. This is I'm doing to take out entire chunk of adnexa. This is a right adnexa. And believe me, after taking out this adnexa, you will be able to see that how much space we are getting for this dissection. That's the round ligament. So taking out adnexa means taking out round ligament, ovarian ligament, fallopian tube, and IP ligament. These four things you have to dissect. Here I'm very close to the rectum. So I have to have proper idea where the rectal serosa is, and according to that I have to go and apply energy. So you can see I am continuously, this is the right ureter, it is shown here. I'm continuously moving around the adnexa to take it out because I don't want any injury. Now this is ureter which is entering into the ureteric tunnel or tunnel of Bardheim. And that's the adnexa which is on the right side, which is out. Again, same thing. This is a rectal fat. I'm assessing the situation because rectum is completely adherent to the posterior wall of the uterus. And now we want uterine artery ligation from its origin so that we can go and clip or ligate or coagulate, whatever way you are comfortable with. Now this is ligation of uterine artery from its origin. Now this is very important and very interesting part. You can see here I am injecting vasopressin on the posterior wall of uterus. Why it is? Because I want neat and clean dissection on the posterior side. Sometimes I will have to use scissors. Whenever I have to use scissors, there are more chances of bleeding from the posterior wall of uterus. Whenever there is bleeding, my area of dissection is messed up. So that's why I use vasopressin. I inject little bit of vasopressin in the posterior wall of uterus so that it will be blanched. And you can see here I'm working. I cannot say beautifully because I cannot raise myself, but then I'm working there and there is very less bleeding. That is because of vasopressin. So now I have complete plane and I know where I have to remain. So that's why I'm working here with ultrasonic energy. Again, this is fat, and now I have to remain above the fat. When I was in pararectal space, I had to remain lateral to fat. Here in this area, I have to remain above the fat. Okay. So you can see yellow fat, I'm remaining just above the fat. Area where I was doing dissection was the vaginal tissue. So I have changed my dissection area from vaginal tissue. You can see here that's the vaginal tissue. This where I am doing dissection is the posterior vaginal wall. So I'm remaining just cut to the posterior vaginal wall and rectum. So this is almost complete dissection in this area. This area is not affected by endometriosis. You can see there. This is just to complete our dissection. You can see that there is no nodule, no thickening of the tissue. We can go still even deeper down there if at all it is, involved. But in her case, in this case, it is not recommended as there is no involvement. As such, all the affected tissue we have to take out. So doing only TLH is not the answer. This is the Deven fascia. So while doing TLH is not only TLH is not the answer for endometriosis patients, because many a times you get patients after TLH who, because of left nodule inside, patient will suffer, and we will have to go in again and operate it again. This all are the affected tissue which we have to take out. You can see there we are working on the left side. And it is always recommended to go for complete surgery, even if it is TLH. Believe me, doing surgery after TLH in endometriosis, second surgery for some problem, it becomes very difficult. Now we are working at the level of isthmus. Here you have to take care, utmost care should be taken about the ureter. High chances of ureteric injury at this particular point. You can see my assistant is giving me indication that I should not go beyond this point as he is holding ureter. Can you see here? Ureter is being held by my assistant. So it is border for me, which I should not cross. That is for the safety of the ureter. Again, we are working at the level of isthmus. And same thing, you can see my assistant is holding tissue near the ureter, which guides me that ureter is not far from my dissection area. Now this is ultimately colpotomy and suturing, which I usually use vaginal manipulator and colpotomizer, which guides me till what extent I should go for dissection. I always remain very near to the cervix, keeping all the vaginal tissue so that there will be less chances of vaginal shortening and post-operative dyspareunia. So this is how this surgery should look like. This is a first picture and comparison. This is the last picture. And this is all. So thank you, everyone. These are the our Facebook and YouTube channel where we do live surgeries. So anybody is interested to watch our surgery live, they can go to our Facebook and YouTube channel. And with that, I would again like to thank Dr. Sejal Madam for giving me such a nice opportunity. If we have time, we can take questions also, if at all we have time.
So thank you so much to Dr. Deven Jogal sir for sharing sir in such in-depth knowledge on endometriosis and mathematical steps how we should perform our surgery. I would like to request our chairpersons to say a few words and summarize on this topic.
Thanks, Dr. Deven, for your wonderful presentation. It was really, you have given each and every steps meticulously. You have explained every step how to cover. It was really eye-opening for many of us. Thanks, Dr. Deven.
Thank you, ma'am.
Congratulations, Dr. Deven. Very nice surgery. And, your videos are very good. And all the steps you had marked, the ureter and rectum and Denon-Willis fascia. So it was very clear for the audience to understand how to take the precautions.
Thank you, Aarti ma'am. Thank you very much.
Yeah.
Thank you so much, Deven bhai. Thank you so much for being here. And Deven bhai is our Gujarat jewel. So wonderful video. Thank you.
Thank you. Thank you.
So, let us
Now,
the panel.
now,
If you are
now
there, please keep ear in panel. Yeah.
Yes, yes, yes.
I have started sharing my screen, so is it visible to everyone?
Yes, yes.
Okay, ma'am. So next we move on to the last panel discussion, and this is the last part of the webinar. And for the panel discussion, I would like to introduce the speaker, Dr. Aarti Luthra first, and then I would request Madam to please introduce the panelists. So Dr. Aarti Luthra is a fertility specialist and gynec endoscopic surgeon at the Luthra hospitals, and she is the immediate past president of the Dehradun Obs and Gynae Society, and she is also the joint secretary of the Uttar Pradesh IAGE. And she's the Uttarakhand coordinator for FOGSI Endometriosis Committee 2021 to 23. And Madam is also the founder chairperson of Uttarakhand ISAR and 2018 to 2022.
Yeah.
And ma'am is the North Zone coordinator for FOGSI Medical Disorders in Pregnancy Committee. And she is a well-known faculty and speaker at various national and international conferences, including AAGL, IAGE, AICOG, ISAR. And ma'am has a special interest in endoscopic surgery, infertility, and high-risk pregnancy. And if we list the achievements, I think it will take another 5 minutes for us.
Oh, thank you. Thank you. Yeah, we can. Thank you, Dr. Sejal.
Thank you so much, ma'am.
Yeah.
Thank you, madam. Thank you.
Thank you for having me here with all the dignitaries from all over India, from Ludhiana, Ahmedabad, Bilaspur, Raipur, Bhuj, and Mumbai. So we are going to discuss complications in laparoscopy, how to identify and how to avoid. Can I see Dr. Nitin Shah around? He's a well-known figure in the field of endoscopy. Dr. Nitin, hi, good evening.
Slide I have already put it on the slide share. So,
Yeah,
ma'am, if you could please introduce yourself.
So nice to see you. And he's an achiever and he's a world record holder for removing heaviest torsion of round ligament fibroid or for large ovarian cyst. And of course, Nitin has summited Everest Base Camp, 18K feet above sea level senior comfortably. And he's TMP guide at WealthCon. So an academician, an adventurous, and a sports person. Always good to see Dr. Nitin.
Thank you for that. Thank you, madam.
Our next expert is Dr. Deven Jogal, whom we have already heard. He's from Bhuj and he's well known for his excellent videos, which he shares regularly on WhatsApp and YouTube. And he's head of minimally invasive surgery department, Deven at Adani Medical College, Bhuj, Kuch. He's member of
video review committee at AAGL. I think it's always exciting to review all those videos and score them because I've been doing it regularly. He's executive committee member IAGE 2021 and executive committee member of some other organizations. He's established first dedicated gynec endoscopy center at Kuch. We welcome Dr. Deven and hope you guys will be with us. I know it's evening OPD time. I would like to welcome our next panelist, Dr. Pratibha from Bilaspur. Dr. Damodar is busy in the OT, I believe, so he won't be joining us. I'll welcome Dr. Pratibha Makheeja, who's consultant in ART unit at Makheeja IVF Bilaspur, Madhya Pradesh. Welcome, Dr. Pratibha. Our next panelist is Dr. Priyadat Patel, who's gynec endoscopic surgeon and fertility consultant at Balaji's Horizon Women Hospital, Science City, Ahmedabad, Gujarat. And he has attended many national and international conferences. And his prime area of interest is gynec endoscopy and infertility. Our next expert is Dr. Rashmi Sharma, who's a senior consultant at Apollo Hospital, Bilaspur, and Dr. Rashmi is president FOGSI Bilaspur. Welcome, Dr. Rashmi. And I would like to welcome Dr. Ritu Jain. She is Secretary Raipur FOGSI Society, and she's Secretary Raipur Menopause Society 2022 to 24 as well. Dr. Ritu has achieved many accolades, including Best Paper Presentation at Menopause Con in 2019. And who else is around?
Ashwat sir has joined. Ashwat sir has joined.
Good evening, Dr. Ashwat. Good evening.
Hi, I'm here.
Dr. Ashwat is, the guru of all of us. He is well known for sharing his excellent tips which help us improve our skills. A very warm welcome to you, sir.
Thank you,
And,
madam. Thank you, Sejal.
Dr.
Thank you.
Ashwat is going to be the senior expert for the panel, and all the difficult things we are going to take sir's opinion. Thank you for joining.
All my juniors are now very good. Actually, they are doing better work than me.
That is because of teachers like you, sir.
Sejal, Nitin, everybody, or all. Deven, Priyadat, all of them, all your panelists, Ritu, everybody are very good. No problem.
Yes, sir. All credit goes to teachers like you, sir.
In fact, at every step, I would like to have a comment from you, sir. I know your comments are...
Okay, anyway.
Yes. Is my screen visible?
Yes, your screen is visible.
So after watching the nice video on endoscopic surgery, we are going to discuss avoiding complications in endoscopic surgery. I know nowadays endoscopic surgery is the most recommended way to do most of the gynec pathologies, including benign and malignant. But still, we have to be careful in avoiding the complications during endoscopic surgery. So can I ask Dr. Nitin Shah that, what are the points which we should keep in mind to avoid complications in endoscopic surgery whenever we plan a case, like if there is a patient with large adenomyotic uterus? So what are the points which should be considered to have a safe sailing during surgery and post-op periods?
Basically, the surgeon should know his expertise, number one, whether he will be able to do with the endometriotic surgery, whether he knows lateral pelvic wall dissection, ureterolysis, whether he'll be able to remove entire adenomyotic nodule and do a flap suturing. So surgeon's competence is very important. Case selection is also very, very important. Which center you are operating, what facility do you have at your center? Are you going to have a 3D system or you are going to operate on a 2D system? Whether you have a specialist, whether you have a specialist involved like urologist, surgeon is around. So case selection is also very, very important. Center, which is very, very important. So I think that will be a take-home message that one should not try to venture into all the surgery, whatever come across.
Absolutely. So patient selection, the surgeon, as well as the equipment and all the best gadgets, the best camera, the best cautery, and the best vessel sealers will help us sail through easily.
And one more thing, Aarti,
Yes, sir.
Aarti,
Yes, sir.
right. One more, just the pre-op assessment of the patient, especially pre-op like thyroid or anything is there, all the pre-op ECG, all these things are a must. See, when we are traveling, when we go to different places to operate, many times we see the patient on the table. Okay, so we have to be we have to have a habit of either getting all the results before hand. Previous day they should send us all the results. So otherwise, many times which I have landed in complication is on table while operating only I am knowing that the blood is not arranged. Okay. Once what happened was that on table surgery was over, patient was not coming out of then I just asked what is the problem. Then only anesthetist is checking the thyroid value. Thyroid TSH was more than 100. And the patient was on ventilator for the next 2 days. Okay. So it was only a diagnostic laparoscopy which was done.
Yeah, yes, sir. So pre-op
Okay. So
fitness.
pre-op assessment of the patient, rest Nitin told very correctly. Only as all the juniors here, they are all very good surgeons, but when the message which given what Nitin can operate or what Deven can operate cannot be operated by a beginner. So they should know that it has a learning curve. Everybody listening to this should know that there is a learning curve and you have to go through this learning curve. And all these people, Nitin, Deven, everybody, whatever, all of you, they have all gone through that process actually. We have all gone through that. So that you should understand the first day one, go and operate a TLH, create complication and lose your confidence. That should not be the matter. Okay.
Thank you, sir. It's very important for having pre-op fitness and pre-op assessment by the surgeon himself and imaging by the surgeon also, because then you know where the myomas are, what is the location of adenomyotic nodule, and then you can go at the right point to make an incision and get the best outcome. So can I talk, Dr. Pratibha, like when you start doing a case, what could be the position related complications which come to your mind?
Like after all pre-op assessment, if I take the patient, I look at the physique of the patient, whether she is thin or obese. And depending on the obesity and thinness, the first point which I will take, like the insertion of the Viris needle. So if she's very thin, then I will look at with the proper instruction, I will just lift up the abdomen and with only 30-degree at the angle, I will try to insert that Viris needle and add that to the umbilicus. And if she's too obese, then it will be vertical for me. Perpendicular.
What about the position? Do you let your OT staff make any position, or do you make sure that the patient's position is correct before starting the surgery? The position of the knees and position of the legs, proper lithotomy position.
Yeah, madam, proper lithotomy
on that. Okay. So now my question is, do you like to create pneumoperitoneum with Viris, or do you prefer direct entry? And what are the plus and minus points of each method of introducing pneumoperitoneum? Can I ask Dr. Yeah, if you want, you can comment. Otherwise, I will ask Dr. Rashmi, and let's see what are her views on access-related points.
I'm always in habit of using Viris needle. I'm comfortable in using Viris needle with proper lifting up the abdomen and putting up the Viris needle.
Okay. So can I ask each person's opinion, because I am used to introducing direct entry of trocar, and again when we go direct entry, it could be blunt versus sharp trocar. So all the experts
Whenever there is not
ask?
one standard technique, there are so many techniques.
Yeah.
Okay, for the entry, because there is not one single technique which is risk-free entry. What we say, risk-free entry, whether you use Visiport where you have an optical trocar, or whether you go by Viris or you go by direct trocar technique, the risk of injuring of the underlying vessel or a bowel is always there. So direct trocar technique, what we are worried about is major vessel injury, because you cannot prevent underlying bowel injury if there is an adhesion, even by going by Hassan's technique, which is an open technique. So our aim is to prevent major vessel injury. We should not do major vessel injury at any cost, because the outcomes are very dreadful. And at particular center, we may not be able to manage that. So our first aim is to prevent major vessel injury by, so either you can go direct trocar technique, which can be supraumbilical, umbilical, or use of varies, whether at a Palmer's point or a J point. That is very, very important. So knowing yourself, master one technique and have another as a backup technique.
So Dr. Priyadat, what is your opinion about the primary port entry? What are your preferred sites for primary port entry?
Madam, we are going directly through transumbilical, not supra or infraumbilical. It is a modified open technique. We just put a small nick over the center point of the umbilicus and incise the sheet. But two practical point I would like to take, give is I always used to palpate the, try to palpate the major vessel through umbilicus, because that indirectly sends us the caution. So that is the first thing I always do before entering inside the abdominal cavity. And second is I always avoid forceful entry, because major complication, whether you go for varies or direct trocar entry, will take care, happen during the forceful entry. So these are the two common practical point. I always, whatsoever the hurry or emergency is there, I take to apply during my entry. And it is a dictum, once you successfully enter, your 70% job of laparoscopy is over.
Yes. But one important point is that entry through umbilical is not the rule. Suppose if you're working for large fibroids or large ovarian cyst, or if it is previous 2 or 3 laparotomies, then
irrespective of that, madam, we have not faced any difficulty till date. So our primary port entry is always through umbilicus, transumbilicus. Then if the pathology is large, under the vision we create another port supraumbilically, not supraumbilically, at near xiphisternum in a midline. Second 10 mm port for a visibility.
I'd like to take Dr. Ashwath's opinion on this.
Yes, madam. Yes, Aarti. See, according to statistics, when you say statistics, whichever we enter, whichever way they enter, they say the complications are the same. But for all the beginners who have been doing it for last 20 years, as we become more and more cautious and as it goes on. I used to direct entry, I used to do very frequently, but now I select the patients. Okay. If a patient is with multiple surgeries, or a patient had a previous hernia surgery, or a patient is a very thin patient, in all these cases, we end up varies at the Palmer's point, which is the least. So put varies to the Palmer's point, and so maximum the complications are less. I will tell you yesterday's event actually. See, it's not day. So I teach so many students in that teach. So yesterday my student put the varies into the stomach. Okay, and when she was telling, then she called me. So I saw that the whole abdomen was having some difference of contour. So I took out the varies, I entered to the Palmer's, and then I looked, the whole stomach was full distended. She has put the varies in the stomach and put the gas inside. Then I had to put the right tube, deflate it. Then as you asked, what is the advantage of a varies? Okay, see, varies entry always you encourage the juniors, because the injury due to varies, the complications are less. Even if you have missed a varies entry in a bowel, should not miss. You missed a bowel, has touched and all. Many times, conservatively, if you keep for NPO for 2 days, it goes, it's closed by itself. So it is not like with the trocar. Trocar, if you are injured, then you have to suture it. Okay, wherever, as Nitin told, complications on the vessel and all these things are very dangerous. So whenever you have any doubt, you have to be very careful. So the matter entry, so in difficult cases, I entered through Palmer's point with the varies. Other cases, I will do direct entry. So this is what I follow and teach the students.
Thank you, sir. Thank you. So, Dr. Ritu, you have to watch this small video, and then you have to tell us the mistakes and how should we avoid this. You can quickly watch the video. So, this is a TLH being done, and the operator is, trying to tackle the McEnrods at this point. And supposedly they have used a colpotomizer also, because the uterus is nicely being pushed above. So you have to point out what has gone wrong and how can we avoid this happening to anyone while operating.
Colpotomizer has to be pushed inside when we are incising it.
Yeah. So what has gone wrong here, Dr. Ritu?
So most probably they are going to injure the ureter at that side. If this colpotomizer would have been introduced properly, it should be visible from above when we are incising, when we are doing colpotomy.
Now you can see this rent carefully. When the operator is trying to clamp the thing, I'll just play the first 10 seconds again, and you have to see where the rent is caused. See, now the operator is trying to tackle the McEnrods.
Yes.
And you can see the bladder fold going till here. Yeah. And just now see the rent. Just see the rent coming up. So this is not ureter. You have to see where the rent is coming. See, what's this?
They have entered
Urinary bladder. Yeah. So
it was not.
Bladder is open.
Yeah, but the operator is smart. That guy has opened the bladder, but at the same time, he's picked up also that he has opened the bladder. Then he's trying to push the bladder down. And now, how will you manage it? Maybe we can take Dr. Deven's opinion if he's around.
First, complete it and then repair it. Complete the TLH and repair the bladder.
So what are the other methods? What are the other methods to identify bladder injury while operating?
One is we will see the Foley's if it is inserted. Second
is a large rent. You can see the Foley's, and then
visible the rugi of the bladder inside will be visible. And you will also see hematuria in the collection.
And one very practical point is always keep the urobag checking. If the cap of the urobag is closed, suddenly it gets inflated because from the bladder the gas passes to the urobag, and you can see urobag full of gas. So always keep checking the urobag also. Of course, there can be hematuria, and if it's a big cut, the urine won't be seen obviously unless you cut a ureter from where the fresh urine will be coming, because most of the patients are catheterized at the time of surgery. So any points from Ashwath sir on
you can see there are so many things. Aarti, you are correctly told that point of pneumaturia. That means the air, many people know. Next, you can put methylene blue as usual. Methylene blue into the creating complication, and to how to avoid it is more important. See, how you can identify the bladder. Okay, the easiest technique is that when you put the Foley's catheter. See, I don't put the Foley's catheter initially. While doing surgery, I put the Foley's catheter without inflating the bulb. I push the Foley's catheter inside. Then the Foley's catheter will curve like this, and you will show the dome of the bladder. Okay. So that especially in case of anticipating is more important, especially in case of previous cesarean. So identify it properly. Then once you become experienced, you will identify the tissue. You know that this is bladder, this is not. Never be casual. And as you told, whenever it's a difficulty, you can push a bulger from below, but you have to be very careful. Don't be overconfident. You have to be very careful cutting it over. Then many times what happens, when will you open the bladder? In previous cesarean, the bladder will be thin. That is not a problem when you operate. Till the bladder is not opened. But when you push it with suction or your other instrument in your hand to push the bladder down, it gets opened. So at the end, you just check that it is not opened actually. So hematuria and hematuria, methylene blue, all these things are different ways of knowing it.
Yeah. And another, yeah, please.
Yeah. We can go for cystoscopy if we know it was a difficult bladder dissection at the end of the procedure. Just to ensure at the end of the procedure.
Oh, okay.
Yeah. And if it is a case of previous to C-section, try to follow the lateral window technique. Don't be over enthusiastic in cutting from the center. Go laterally, go above uterine artery, find a proper plane for separating the bladder, and then you can push the bladder down and complete your surgery. So this is another video. This is for Dr. Priya Datta. And let me just play the video 1 second. Yeah. Dr. Priya Datta, this is a case of redo surgery. This patient has undergone previous myomectomies, and this is a case of multiple myomas. And this time she's for TLH. So the anatomy is distorted a bit. As you can see, the bladder is high up over the cervical fibroid, and the surgeon is trying to navigate. And now we have to see that what has gone wrong while navigating to push the bladder down in this case. Sorry, it's not.
No problem, madam. But I can take your point. What you want to convey is, so in my training of laparoscopy, initially when I did with my mama, Dr. Sanjay Patel, and everybody, Shailesh Putambekar, sir, and everyone, they always say anticipate the complication. So that is what you have to think before proceeding any case. So you first say cervical fibroid. Typically, everything come to my mind that difficulty is between bilateral ureter, bladder dissection, and bladder door. So before proceeding this surgery, in my mind, I am very clear. I have to isolate both sides of the ureter. Then only I will touch the fibroid.
Absolutely.
Because ureteric injury is very common in this cervical fibroid, and one of the newer thing we are facing right now by kind of over aggressive cervical fibroid tackling is sometimes people goes into the bladder wall dissection so below they are injuring the trigone, and that leads to a kind of urinary retention for a longer duration of time. Last 2 to 3 months I have seen 1 or 2 cases with long-term urinary retention after over judicious TLH of a cervical fibroid, and people has to keep the catheter for almost like 1 month and 2 months, because nowadays studies are coming that bladder trigonal injury will lead to a retention and urinary problem in a longer duration of time. So the things I want to convey is whatsoever the case you are taking in your practice, anticipate the complication. There will lead to a reduction in complication in half of the cases.
So how will you tackle this? The surgeon has transected the ureter while trying to dissect the cervical fibroid as stated, because the anatomy is distorted. So what would be your approach to tackle this injury, which is a clean-cut ureteric?
Clean-cut ureteric injury with proximal stump more than 1.5 centimeter, you can go for end-to-end anastomosis. That is very comfortable and easy, provided that thermal injury is not that big. Because big thermal injury may require a resection of a part of a ureter to get a good vascularity of the ureter. So that is first thing is. So for an end-to-end anastomosis, we generally do DJ stenting through laparoscope only, and both side of the ureter has been sutured at a 312, 6 and this 9 o'clock position. We generally use suture material that is a Prolene, particularly 50 or 60, that is very comfortable. That is what we use in our practice. Partial transaction, you can kind of be forgiven with DJ stenting with 1 or 2 stitches with the 40 or 50 Prolene. But if the proximal stump is less than 1.5 centimeter, be assured to go for end-to-end anastomosis. That is going to be a very not forgiving, and you might require direct implantation with bladder mobilization.
and then we can do omental flap transposition for better healing.
Madam, I have a disagree with the omental fat transposition, because nowadays, even in VVF also, and even in all the anastomosis and this thing, generally there are two school of thought. You may require omental transposition, you may not, because ultimate aim is to have a good vascularity, watertight, watertight tension-free anastomosis. So in our practice, we don't go for omental transposition in ureteric injury and ureteric this implantation.
Okay, but you leave a stent for about 6 weeks.
100%, 6 weeks, 100%.
Yeah.
And post removal stent, see, the thing is, before 1 week before of 6 week, we go for CT IVP, and even after removal of stent after 6 week, again we go for CT IVP after 1 week of removal of stent.
Okay.
That's
Thank
for
you.
documentation purpose only.
Yeah. So we will invite Dr. Ashwath sir for your expert comments on ureteric injury.
All difficult cases, as Priyadat exactly told, all difficult cases. I don't do routine. I don't believe in doing routine ureteric dissection for all cases. But in all difficult cases, like cervical fibroid that you have shown, you should do ureteric dissection. So putting stent, pre-op stenting also sometimes becomes very difficult. If you are a beginner, better to put a pre-op stent actually. Pre-op stenting, you can identify, it is only helps to identify, but dissection becomes difficult actually. But you should not say not to put for the juniors, because if they put, they will identify the ureter, and if you injure, no need to worry at all. Just put one suture over that stent. Okay. As Priyadat told, one point is very important, is that if there is no adequate distal, that means the proximal, whatever nearing the bladder is not there, always do an ureteric reimplantation. See, ureteric reimplantation is also an easy technique. So don't worry, you open up the bladder fundus and you push it inside and mobilize the ureter and push it inside. As he told, nowadays, omental flap and all these things, not, if you want, you can keep, nothing wrong, but proper vascularity, tension-free anastomosis. That is the most important sentence, tension-free anastomosis. So this is important. And now the juniors are accustomed to ureteric because we are doing more and more extensive endometriosis. Okay, so they are seeing ureteric injuries. Identifying is the most important, Aarti. Identifying is the most important. If you miss something, and even if you think that a coagulated and that area has been coagulated, nothing wrong. Put a stent from below after the surgery for 6 weeks and come out. So instead, after 10 days, urine leaks, that your trauma, not only the patient's trauma, a patient, most traumatic is that patient coming with post-operative VVF. Sometimes to manage is very difficult. And one more thing, as you go below to the trigone level and all, or to the bladder neck, if fistula occurs, it's a headache, real headache, actually. So we have to be very careful, identify it. That is the most important. That is the only thing. Identify doing surgery, repair immediately. That's it. That's the message. And to all juniors, be careful, anticipate the cases, do proper ureteric identification. At least if you are not able to do a ureteric dissection, you do an ureteric identification before putting clamps. Okay.
Thank you. Thank you so much, sir. Dr. Nitin Shah, when would you like to do cystoscopy after pelvic surgery? Because it is not recommended to do it in routinely. But what are your doubts when you want to put in a cystoscope post TLH?
Especially when we do previous 4 cesarean section where the bladder is badly adherent. In that all cases, we do a methylene blue dye test, and sometimes we do cystoscopy. Otherwise, cystoscopy is not routinely required. But if you have a doubt, better to put in a cystoscope. We always have a hysteroscope with us. Go inside, have a look at the trigone, have a look at the ureteric orifice, have a look at the jet. Sometimes in the era of endometriosis or lateral pelvic or plaster, where you are not able to see ureteric peristalsis, better to have a, cystoscopy can check by the ureteric jet. So that is the only indication, where your ureter is not visible and you have not done lateral pelvic wall dissection, you can go and check the ureteric jet on the cystoscopy.
Yeah, thank you. Dr. Pratibha, this TLH is done nicely. We have sutured the vault, and now the surgeon sees that there is a superficial bowel injury by energy source, which is only 2 to 3 millimeters, which is not full through and through injury. So would you like to leave this patient? How would you like to manage this superficial bowel injury by thermal burn?
Usually serosal injuries heal on themselves. And if it is more than 3 centimeters and if it is more in depth, then only we'll recommend suturing of the bowel.
Okay. So
better to keep a drain. Whenever in doubt, keep a drain.
Yeah, drain
That is
also.
very important. Drain
And,
is very, very important in such cases. Or take a few superficial stitches.
Even if Ardi, I feel that put one stitch over it. See,
Yes.
always whenever you have,
Yes.
see, even if they see, sometimes you have used harmonic touch on the bowel. At the end, if that blanching has not gone, just now you are putting just one put a stitch. Nowadays we are all expert of putting stitches, so one
Yes.
stitch extra doesn't matter at all.
Absolutely. Thank you so much, sir. So,
I would like to add,
Dr.
thermal
Pierre.
injury, it is preferable to take a stitch rather than, going by a chance, because you don't know what is the depth of penetration of thermal injury irrespective of size. And the another thing is, if even if you have kept a drain and patient leaks, it is going to be a haywire. So rather than taking on chances, it is better to take 2 or 3 stitches over there.
Yeah. Thank you. Thank you for having the same opinion. And basically, this stitch is only seromuscular stitch. We are not going through the mucosa. And this repair gives us a comfortable good night sleep also. Yeah. So this is, the video is just loading. So this is an over-enthusiastic surgeon doing bilateral endometriotic cyst surgery. And again, we have to see that what are the errors. This is a very old video. What are the errors in the surgical steps and what shouldn't have been done to avoid landing in trouble?
The ureter is very close to the ureter. That ovary should be lifted up actually, and he is very close to ureter basically, and he should have put in vasopressin prior to dissection.
How will vasopressin help?
Ma'am, like if we put vasopressin in the uterus, there will be less chances of bleeding, and it will be easier doing cystectomy.
So I would need the opinion of the house. It is recommended to put dilute vasopressin in all cases of endometriosis or myomectomies. What is the preferred method used? Dr. Patel can tell your experience, or Dr. Nitin, yeah.
Yes, we generally use diluted vasopressin in severe plastered frozen pelvis. Just inject few cc of dilute vasopressin in the fundus of the uterus. What it helps is it blands the neovascularization, which is there all over the pelvis because of the endometriosis. So once that neovascularization is taken care of, the adhesiolysis become easy. The plane gets more, it gets easily, you can separate the plane more easily. As you can see, many of the Sanjay Patel sir also uses diluted vasopressin in all of his surgery. So use of vasopressin makes even endometrial cystectomy very easy and less use of energy sources. So that is very, very important.
Yeah. So this is an over-enthusiastic surgeon, and the way we discussed earlier also, stay close to the uterus. So while in an attempt to separate the cyst wall, the surgeon has opened the bowel wall also, because the planes were not very clear, and the dissection has been vigorous. It should be, I think when the adhesions are there, the dissection should be fiber by fiber and very slowly. And the surgeon has been towards the bowel rather than being close to the uterine wall. So yeah, Dr. Ritu, what are the ways to avoid it? Yeah.
We have already discussed, as Ashwath sir also told us, millimeter by millimeter dissection, be close to the specimen, use vasopressin as pointed out. And if we can trace the ureter preoperatively, because we are going close to it and the anatomy is anyways distorted in endometriosis cases.
So for that
and
bowel injury, would you like to do a primary repair or go by some other method? What would you do for that?
for bowel injury, if the
Yeah,
patient
the one which the surgeon had done just now.
yeah, if the bowel is prepared, GI surgeons do recommend for the same stage sitting repair. But if your bowel was not prepared and it is a contaminated, then you have to do a colostomy and come out.
I don't think primary injury colostomy is indicated. We can nicely, clean up the field.
The bowel be prepared.
फिर ऑपरेशन कराना है
So, we can mute, the other people's mic who are not speaking. Ashwath sir, need your expert opinion for that.
Okay. See, the same things. See, you have to operate. See, here what happened, the plane has changed. That is, the surgeon has gone in a wrong plane. So when you have gone in the wrong plane, you should get the feel. One is that excess bleeding will be there. And the feel of the tissue will be different. See, a bowel and the uterus, the feel will be different. So unless first word itself, Nitin told in the beginning itself, only attempt cases which you can do. This happens usually when patients attempt, the surgeons attempt which they cannot operate. So the carelessness is one point. That is, leave about that carelessness part of it. So here, once you have opened up, I don't believe in this colostomy part of it nowadays. We freshen up the edges and suture it. Ritu has told correctly. If you call a surgeon, that is the problem. What happened? We are more experienced. When a surgeon is being called to, first thing what they will ask you, did you prepare the bowel? So many times the injury happens in cases where we have not prepared the bowel. So, so we should convince them. So most of the time you excise the edges because it's a thermal injury, edges properly, see to it that then you anastomose it. So we most of the time we don't have a cut through injury, like separated, the whole bowel is separated into two and all these things, then it's a different. Then you should understand in which case you are operating. See, you are operating on a PID with full pus and all these things. In that cases, you are correct, Ritu. We will not go for a primary repair. The pelvis is fully infected with pus. Then you go for a colostomy. That's only rare nowadays. Very few cases I would have asked for a surgeon to do colostomy and complete the repair after. Nowadays, I don't know. Big people are there. Our Nitin Priyadath and all dealing with so many.
We have to. We have to invite young surgeons, young dynamic surgeons.
You have done a colostomy, Nitin? Have you ever done a colostomy?
Never done. We invite young dynamic surgeon who is good in laparoscopy, so they will suggest laparoscopic surgery. If you call old timer, they go more in favor of open surgery. So you should have a good surgeon friend who is endoscopic surgeon.
I just want to add one thing is nowadays colostomy per se is very rare. If we want to go for a diversion, we go for a ileal diversion. That is for sure. Right. The second thing is the role of diversion comes only in three conditions. One is when there is going to be a tension like sigmoid level anastomosis. So it is always going to be a tension anastomosis that requires diversion. Second is when the residual stump of anal verge is less than 5 centimeter, that requires diversion. And third thing is when you already suture and patient goes having a leak and you have to go for a resuturing, that is infective etiology. These are the only indications that requires diversion.
Definitely.
Apart from that, in routine practice, we never require a diversion. Always go for a primary closure. That is for sure. Counsel the patient very adequately. And if she leaks again, then she might require a diversion in future down the line, 11 or 12 days of post-operative phase.
Always remember about the drain.
Drain is always there. Once you handle the bowel,
don't forget, whenever you have touched the bowel, drain is a must.
Drain is the rule. No option, sir.
Absolutely.
Also, use of blunt dissection will prevent such kind of injury. If you have used vasopressin, if you have used manipulator, just with a gentle traction with the suction, you can do adhesiolysis and prevent the false message or entering into the wrong plane where you open up the bowel.
And then Nitin, correct, but many times sharp dissection is better. Many times than
combination. What I mean to say is
with your
combination. Whenever
expertise,
in doubt,
you will be
avoid
able
use of
to.
field. Yes.
Okay, you will be able to do it. But for the beginners who are listening to our talk, always identify the plane, do sharp dissection. All this when you are cutting with a scissors. Okay. The injury, what has happened, you will be able to suture it in the. But if you are using energy source and cutting, even if an harmonic can cause damage to the edges, actually.
Yeah, definitely.
I'm sharing a video here. The surgeon is doing lymph node sampling for a case of CA endometrium. He's working on the external and internal iliac arteries. So let's see, what has gone wrong here. So we are doing lymphadenectomy and so when I'm playing this video, it's very, very important to have vascular clamps always ready in the OT. We should have adequate suture materials and we should have, if we are not capable of handling the vascular injury, we should have good friends who can come and help. So what should be done once, the surgeon has injured the external iliac artery? What should be done? Dr. Patel can tell us. That's why I have stopped the video here so that we can discuss the management. Now, what should be the right approach? Because everyone in the OT panics once such thing happens.
Even surgeons panic. It is going to be vascular injury is going to be nowadays nightmare for an advanced surgeon, not like bowel or ureteric surgery injury where you can have a time. So first thing is with the blunt instrument, wherever the injury takes place, proximal blockage, if you able to do, is the best thing you can do. And that will give you some time to even think about what you need to do.
Absolutely.
Second thing is pre-operative preparation from surgeon side is very important because this kind of a injury can take place. Previously, the dictum was जितनी भी surgery करते उतने complication होते. It is always correct. The more you do the cases, the injury can happen. Best of the best day when you are never expecting, or kabhi, we think we want to go out, we'll finish the surgery in 30 minutes and then surgery will end up in like 2 hours or 3 hours.
6 hours. Yes.
Yeah.
Very
So
true.
that thing always happen. So whenever you attempt this kind of a surgery, you should have a good number of Prolene sutures, good vascular clamps, good assistant you have. Camera should always be good. And apart from this, on-call team is very important. That is the most important thing when you are attempting this kind of a surgery. So when I have talked to you previously, anticipate the complication. So one of the preparedness is when you start attempting advanced cases, you should have your own core team which can be there inside your OT within 20 minutes or 30 minutes whenever you require. Because of course you are competent enough, you can do anything, but still in this kind of a scenario, help is always good. Am I correct, sir?
Yes.
Yes. One thing, I will tell you what, whenever there is a vascular injury, which vessel is injured is important. So it's an artery. Okay, imagine. So immediately through the other port, hold on both sides. Correctly, Aarti has shown here. It is her case is very good. Both sides, she has held the vessel. So you cannot hold on one side because it will start bleeding. So artery or vein, you have to hold on both sides. Then you can use and you can suture it. So our injuries are not cut through injuries. We are not dissecting it into two. Most of our injuries are only 1 centimeter injury, which we can put an 8-shaped and with a Prolene 8-shaped, we can put a 8 suture and tie it. And then you release and see slowly it's bleeding again, hold it, put one more stitch. Most of the time. So don't get panicked actually. So, okay, in case you are not able to do, you just hold on both sides and wait for the vascular surgeon to come. So for a beginner, don't worry. And one thing, except for the external iliac artery, all the other vessels, interiliac artery, interiliac vein, and even if you injure and coagulate, also nothing happens. Don't tell, should not comment like that. But even for I had in beginning of the time when I was not able to reach a vascular channel, I injured an external vein. Vein suturing is very difficult. When you are trying to do it, it tears off. Finally, what happened? I coagulated that vein. Imagine what I did. So it's not easy, but and I left it. Patient life was saved actually. Patient had full edema of that leg for long. Then later, after 6 months, we exercises, and then also it was not relieving. Then the vascular surgeon did the venous graft. Patient is perfectly okay, and she's very thankful to me. So, so it is what the confidence. Nothing to worry. You have put a laparoscope. You are seeing the injury. Only vascular injuries are dangerous when you are doing it blunt. That means you are injuring with a trocar. It is very dangerous. When you don't know, in a dissected vessel, you can suture. In an undissected vessel, it is very difficult. When you have injured with a trocar on an undissected vessel area, so better to go for laparotomy and hold it very fast. So, for example, you have been injured on a aorta with a trocar. You have not, but when you are like Deven and all do lot of aortic dissection, that means para-aortic dissection and all, I have seen his videos. So when you do a para-aortic dissection, I'm not a routine para-aortic fan of, I'm not doing it routinely. When you once in a while, I get cases, that is why. So when you get para-aortic dissection, when we do, we have to be, then you injure, you are skeletonize the vessel completely, you can suture it. But you have bluntly injured a vessel, you never try to hold it like bluntly. Then you immediately laparotomy. So nothing, what I feel the message should be, nothing wrong in opening an abdomen. A vascular injury is something cause death of the patient. So whenever you are cannot tackle, open up. And there is a clamp which is available. I always popularize students. That is called the Statinsky's clamp. Statinsky's clamp is, I cannot show it now actually. It's a curved clamp like this. So if the injury, you can hold it with the one clamp, you don't have to clamp it on both sides. You hold it with one clamp, your injury will be in the center like this, put a suture. So with one clamp itself, you get it in all surgical, and you don't have to have a laparoscopic Statinsky clamp, which is very costly. Other clamp is only 10,000. You go to a surgical, any surgical store, ask a Statinsky strap and put the through a, make your 5 mm, 10 mm, put it fast through the 10 mm port, hold that vessel like this and keep it. Then you slowly suture. So holding on both sides and keeping, that is the most important. Dr. Ardi has shown it very well. So don't panic. But she has injured a dissected vessel. That is important. When you have injured a dissected vessel, only so confidently you can suture. So remember this 3 points which I throw years which I have learned actually.
One thing I would like to add is, Madam has done a wonderful job. Create an extra port if you don't have an access point. So that is one thing. And the second thing is large vessel injury more than 5 mm, you cannot suture directly. You have to suture with the Teflon support, because if you suture directly, it will create a diverticuline later on, and then you discharge the patient, and after the discharge, maybe 7 days or 15 days, she'll come up with the diverticular rupture. So large vessel more than 5 mm rent should be sutured under the guidance of vascular surgeon with the Teflon support. So that is what I want to take.
And one more thing, Priya, that they have to be very careful about the thrombosis part also. See, one of my patients sutured had pulmonary embolism and death actually. So all these things, we will be very careful. I have sutured vessel and all this. Don't so casually tell juniors. See, all this, another patient, I'm telling you, for years, 20 years, another patient had an aneurysm rupture and died. See, sutured how many years? 10 years after. So I came to know only last 6 months back, their relative came, they told that patient was suddenly collapsed, and then it was an aneurysm was there and it ruptured and they couldn't reach the hospital. So imagine, see, many things which we do, it's all these things, be careful. As juniors, we do many things actually. So, and we are very confident, we sutured bowel, ureter, we anastomosed, all these things, we do it like that. But as years goes on, we understand that we come to know about the complications that happen. That is why when Sejal called me, I told, okay, I will come and sit as a panelist.
We were very happy to see your name, sir, because we want the seniors' comments. So thromboprophylaxis is very, very important in such cases. And it will be better to do a Doppler study also post-op, maybe after 2 weeks, to see the flow patterns. Thank you, sir. So this is another case. This patient on day 2 post-op, after lap endometriosis surgery, she is complaining of difficulty in walking and paresthesia. So how would you explain it, Dr. Ritu?
She has to.
Yeah.
She will have to undergo physiotherapy, and we have to
No, what
counsel
could
her.
be the reason? Why did this happen? How could we prevent it? First, we have to understand why we did a good surgery and the surgical aspect is good, but she's complaining of difficulty in walking. What could have gone wrong?
Neuropraxia or nerve injury at the time of dissection. So we have to counsel her regarding
Not at that time of dissection. Dr. Patel, what is your opinion?
Madam, it is due to compression of lateral peroneal nerve. And that is because of the position of the patient, that is extended lithotomy, uncomfortable position, and angle of the stirrup as such that prolonged compression can lead to that. So comfort of the patient, using of the gel pack at the level of popliteal fossa, and nowadays we are using is Allen. I personally don't use Allen stirrups, but people are fond of using Allen stirrups. So these are the things you can go for. Second thing we do in our practice, because we are not using Allen stirrup, is we use a gel pack. We take care the angle of the popliteal fossa, and during the surgery, every 30 minutes, we want to avoid head low position and keep the patient for like 2-3 minutes in a supine position to reduce the tension. So continuous tension over the popliteal fossa is avoided, and by God's grace, we are happy with the outcome of our patient. But these are the things you can do in your routine practice.
And same is true for shoulder joint also. We have to be very, very careful that both the arms are by the side of the patient and they are well protected. And another thing.
Whenever, okay, Aarti, you can.
First you share.
Nothing, man. And I will share some of your experience. Nothing. See, what we do, these things happen. This is a headache, actually. You know that patient comes and not able to walk. It's there is full pain in the leg or paresthesia and all these things. So what Brother correctly told, one more point I will add to it is if your surgery goes more than 1 hour, if you plan your surgery, you stop the surgery, you make the leg straight, do some exercise like this exercise, and then put again, and then so all these small things. And this compression, stirrups, and all these things are very important. So don't tie it very tightly. If the stirrup is not working properly, you tie one band around and tie it to keep the stirrup like this in your position. Shoulder, I will tell you a small incident. Shoulder patient, you should keep the hand close to and tie it. Don't keep it like this. Okay. And I had a patient who had shoulder dislocation. Imagine shoulder dislocation. And they did not pay the bill, and they went without paying the bill. Imagine, after doing a very wonderful surgery, 100 kg patient, 110 kg patient, DLH with so much difficulty was done. Finally, the shoulder dislocation, they told that it's your problem. We have to accept it because of the hand. How can we say that it's not our problem? So all these things have to be careful, positioning. And one more thing. If it is a nerve injury, it's very difficult to manage. Then you have to, if it's a nerve paresthesia, all these things you can manage. So one of the common nerves which can be injured is the obturator nerve. So if you have injured, you try to suture it yourself or call the surgeon and suture it. If you cannot suture it. Otherwise, patient is definitely going to have problems.
Yes, sir.
Another nerve problem, madam, where you put that everybody knows actually. See, when you put a morcellator port, it's a big port. Okay. So we all have a habit to suture it after putting it with a port closure needle, we suture it, port closure. Never tie it very tightly.
Yes.
If you tie it very safely and get it nerve entrapped, the patient will always have ears, patient will bother you with. These are all small tips. I know that most of you would have had this, but why we put port closure needle? Just to approximate it. You just have to approximate the sheath. You don't have to tie it tightly like this. Just approximate that hole. So all the small tips which I told about paresthesia, nerve injury and all.
That's very true. Most of the myomectomy patients, they'll complain of pain at the port site only. So, Dr. Rashmi,
sorry to disturb you. We can still continue, but in a little rapid way.
Just 3 minutes more.
Yeah, sure.
With Dr. Ashwath's tips, I think it's getting more interesting. And
No. This is only experience.
I don't want to interrupt you, but it's already been like.
I understand.
Okay, I will also have to leave. Correct,
We're
Sejal.
enjoying
With
actually
the
a
enthusiasm, I am sitting.
But we have just 2 slides and then we'll say thanks to you.
Yeah,
So, so just 2 slides. We want you to leave by the end of it. This will all know trocar site hernia. We should not miss it if the patient comes on post-op day 7, and we should always keep it in mind. And late complications like port site infection is pretty common. If we are not sterilizing the trocars, or if we are not using disposable trocars, till few years ago, we were seeing mycobacterial infection at the port site also. Nowadays, we are using disposable trocars. So this complication has gone down. We all have to safeguard ourselves for litigation. So we must take proper consents. We must explain everything to our patients in detail, and do not denigrate colleagues if you see a complication created by your colleague, and remain in communication with the patient, and always notify your medical defense if something goes wrong. And, we all have shared a lot of take-home messages. I would like to thank everyone, especially Ashwath sir, for his special comments, and his experience matters a lot to all of us. And thank you so much, Sejal. And now we can give a concluding remark. Thank you so much. I'll stop sharing my slides.
Actually, we never want this panel to end, because of complications are always very interesting topic, and that overcomes our all fear in endoscopy. And beautiful video collections, ma'am. And the confidently you have managed each cases. So it was very interesting panel. Thank you so much, Ashwath sir.
Oh, thank you, Sejal, and thank you all. I was so happy to sit with all are Nitin, Priya, all are my students only. So, and Dr. Arati, everybody. So that is why I thought I was not having time. Then I thought that somehow I will be here and share my some complications and through the experience. That is more. But I know that now the surgeons are better surgeons, and all of you are much better than me. But complications and experience through years of evolution, that is what we said. Happy to giving a chance to share. And Sejal, all the best for your, especially, and I want you to see as a chairperson of Endoscopy Committee. Thank you, everybody.
Thank you so much. Thanks. Always a pleasure seeing you, sir.
Thank you. Thank you, Aarti ma'am. Thank you.
Yeah.
Thank you, Rashmi ma'am. And everyone, they had nice things to share. Nitin was good as always. So thank you, Sejal. I believe it was a very good webinar organized. All the best and all our support for your candidature also.
Thank you, madam, and thank you, everyone. Thank you, Bilaspur Society, Bhilai Society, and Ludhiana Society for this coordinating everything so well and be here. And I again thank FOGSI Endoscopy Committee and the entire FOGSI for giving this platform to have the academic discussion. Thank you, all speakers and moderator, madam. Thank you so much, all the sporty panelists, and my guest of honor, Dr. Sunita madam and Prakash Trivedi sir. I thanks them all. Special thanks to coordinator. Thank you so much, Piyush and Uma, for always being there.
Thank you so much, ma'am.
Ashwath sir said I will just join for
Thank you, ma'am.
minutes, but then he stayed back for entire session. So thank you, Priyadat, and thank you, Ritu. Thank you, madam. Everyone, so much. Thank you.
Madam,
My
wish you all the best.
Very best.
Thank you.
Yeah.
Just wishing me, please call every president.
Second, sincere worker, and everyone loves you.
Just
I'm very
make
sure.
sure they vote, they don't miss the thing. That is most important. Just make it sure that everyone, every president and secretary of each society vote. Nitin bhai, आप तो कितने रूप में है? Your clothes are there. You're 5 Nitin.
He was on treadmill, I guess.
Atra tatra sarvatra.
Thank you, Nitin.
और पत्र में एवरेस्ट भी included है. Yeah.
Thank you so much, everyone, for joining us. Mute. Yeah, okay. So, with all permission and gratitude, I am really very satisfied with the today's webinar, and thank you all. Let's have one click. Yeah, switch on the video now, everyone. Okay. So, thank you. Bye.
Thank you, ma'am.
Thank you.
Thank you.
All the
Thank
best.
Yeah, thank you, madam. Thank you. Let's see any chat. मस्त रहा ना, मस्त.
बढ़िया था मैम एकदम.
हाँ, मस्त रहा.
Very nice, very smooth.
Laparoscopy के always